Hello and welcome to Acute Respiratory Distress Syndrome, ARDS. My name is David Woodruff. I'm the editor of Critical Care Nursing Made Incredibly Easy. I hope to make this incredibly easy for you too. So let's talk about ARDS. We have a case study here with Mr. Franklin, 25-year-old, involved in a motor vehicle accident resulting in a subdural hematoma, fractures of his right radius, his left femur, his pelvis, and multiple ribs. He's also diagnosed with a pneumothorax. On admission to the emergency department, his vital signs are as follows. He has a blood pressure of 88/48, heart rate of 134, respiratory rate 40, and his temp is 36.1. Now, first of all, when you're evaluating vital signs, remember again, we want to be evaluating each one of these signs and making a determination as to whether or not we think there could be some problems here with hemodynamics. So this is a 25-year-old. You may look at that blood pressure, 88/48, and think, well, maybe it's not too bad. He could be an athlete, right? But his heart rate's 134. So he's obviously tachycardic and tachypneic, which could be due to his pneumothorax. But I would have to say that due to the pelvic fracture and his femur fracture, these are two fractures that are associated with having a large amount of blood loss, it is very likely that this patient probably has had some blood loss and is in shock. So I'm going to look at those vital signs in those terms as to this patient is in shock. Chest tube is inserted, he's intubated, stabilized, and sent to the ICU. On admission to the ICU, his vital signs are as follows. So his blood pressure is 104/46, looking better, right? Heart rate of 118, respiratory rate of 28, and 36.1. Okay, it looks like he is starting to move toward the right direction here on the mend. We look at his blood gas, and we see a pH of 7.30, CO2 of 50, bicarb of 20. So when we're looking at the acid-base balance, we can see that bicarb's just a little bit low, so maybe there's a little bit of metabolic acidosis from that shock, and we also have some respiratory acidosis because the CO2 is high. Therefore, we want to make sure that we're treating those things. Specifically, we can take a look at those ventilator settings to make sure that the patient is having an adequate amount of ventilation. Okay, so that's the part that's going to affect the CO2, tidal volume. Then we take a look at his oxygenation. His PO2 is 190, oxygen saturation 99%. Looks great, right? We want to take that a step further, though, when we're looking at oxygenation in our patients. This patient is on an FiO2 of 100% to get that PO2 up to 190. We'll talk about how to evaluate that here in just a moment. So do you think Mr. Franklin is at risk for developing ARDS? In order to be able to make that decision, we're going to have to know what some of the risk factors are for ARDS. Well, let's back up a little bit and talk about what ARDS is in general. Adult Respiratory Distress Syndrome, that was the original term used for ARDS. We've changed that to Acute Respiratory Distress Syndrome because it affects not only adults but also children. And initially, we found out about ARDS in neonates. It was called hyaline membrane disease. The etiology for this neonatal respiratory distress syndrome, a little different than what happens in adult, but the end result was severe lung destruction caused by out-of-control inflammation, ended up being the same in both cases. Now, in neonates, it's the result of inadequate surfactant production, and so therefore artificial surfactant was a good treatment. In adults, it's not the result of inadequate surfactant production, and therefore giving artificial surfactant really doesn't help a whole lot. It is characterized, though, by a compatible history and acute onset of severe respiratory impairment, which we're going to define as being a PO2-FiO2 ratio of less than 200. In a moment, I'm going to show you how to come up with that number. Decreased lung compliance, elasticity of the lung, and this is because we have fluid edema that's starting to collect in the interstitial spaces. Refractory hypoxemia, you turn up the oxygen, patient's still hypoxic. More oxygen, still hypoxic. Bilateral diffuse lung infiltrates. We call this a whiteout on the chest x-ray, and tachypnea. Now at the bottom of the page there, you're going to notice that we have our PO2 and FiO2. So in Mr. Franklin, his FiO2 was 100%, his PO2 was 190. To do a PO2-FiO2 ratio, we take the PO2, 190, and divide it by the FiO2. Now, we're not dividing by a percentage, we're dividing by a decimal. So 100% would be 1.0 in a decimal. So you divide that out and you end up with 190. One of the characteristics of ARDS is a PO2-FiO2 ratio less than 200. And here we are at 190. Risk factors for ARDS. The most common risk factor is sepsis. A very close association between sepsis and ARDS. So we want to be looking for that in all of our patients who are septic. Look for the respiratory involvement. Aspiration is also a fairly common risk factor. Pneumonia, pulmonary trauma, think Mr. Franklin, multiple trauma, shock, multiple transfusions, DIC, and acute hemorrhagic pancreatitis. So when we're talking about Mr. Franklin here, we've got the pulmonary trauma, the multiple trauma, the shock. Boom, there he is. He's got risk factors. What happens in ARDS is we have overwhelming, out-of-control inflammation in the lung. Inflammation causes three things to happen: vasodilation, capillary permeability, and clotting. These things are functional. In other words, they're helpful when they happen in a particular area of the body. For example, you get a cut on your hand, we have vasodilation, vessels dilate, so we get more blood flow to the area, get more nutrients, get those white blood cells there to kill things off, we get those platelets there to stop the bleeding. Capillary permeability, well, we got to let that stuff out of the capillary if it's going to work. So we let those things out of the capillary, we get some capillary permeability. You probably noticed in a lot of patients' wounds that you get serosanguinous drainage. That serous fluid is caused by capillary permeability. Thirdly, we get clotting. Well, you get a cut on your hand, you hope you'll clot, otherwise you're just going to bleed to death from a little scratch on your hand, right? So yeah, we have clotting as part of this inflammatory process. Now what happens in ARDS is we have an overwhelming, out-of-control inflammatory response in the lung. So this inflammation is out of control. The vasodilation initially will help to maintain oxygenation, so you can't see the early signs that your patient's decompensating unless we look at a PO2-FiO2 ratio. Capillary permeability, which is going to cause edema in the lung, that's what results in that whiteout in your chest x-ray, and then decreased perfusion, caused by clotting, little microclots occurring in the lung, causing tiny little pulmonary emboli, decreasing perfusion, causing hypoxemia, causing pulmonary vasoconstriction, which is the response of the lung to hypoxemia, and then further decreases in perfusion. So we get into this vicious cycle here at the bottom of the screen, causing more and more hypoxemia, and then we get into that refractory type of hypoxemia. So Mr. Franklin then continues to stabilize, and 24 hours later, he's alert, he's cooperative, and has the following vital signs. His blood pressure is 124/62, heart rate of 88, respiratory rate of 14. Remember, he's still on a vent. And we got his FiO2 down to 50%. Okay, he's looking pretty good. You think we can extubate him at this point? PO2's 94, oxygen saturation 97%. Well, we probably want to drive that FiO2 down a little bit further before we talk about extubation, but let's take a look at what his PO2-FiO2 ratio is. His PO2 is 94, his FiO2 is 50%, that's 0.5, so you divide 94 by 0.5 and you end up with 188. It's actually worse than it was the day before, a little bit. I would be very concerned about Mr. Franklin. Just be vigilant at this point. Second day after admission, he appears to be progressing well. Ventilator weaning has begun. Vital signs remain stable. We got his FiO2 down to 40%. His vital signs look pretty good. PO2 is 92. FiO2 is 40%. So what is his PO2 FiO2 ratio at this point? So 92 divided by 0.4. Remember, when you're dividing by a decimal, you're always going to end up with a number bigger than what you started with. And that ends up to be 230. So we're over that 200 mark. We're not really back up to normal, but it looks like his PO2 FiO2 ratio may be improving. Now here's what happens in ARDS. So here's the bronchioles, the alveoli. So this is just kind of like one alveolar cluster here. And we get that overwhelming, out of control inflammation that's occurring. And you can see that, first of all, the inflammation begins to destroy those alveolar walls. Okay, because inflammation is meant to destroy bacteria and foreign bodies, but it can't tell the difference between bacteria and healthy tissue. Microclotting occurs in the pulmonary vasculature, and at the same time we're building up this fluid in the alveoli. The inflammation is nonspecific. In other words, it will destroy healthy tissue too. And it can lead to more inflammation as we're destroying healthy tissue. So let's take a look at this vicious cycle over here on the right. We have the initiating factor causing inflammation, causing tissue damage. The tissue damage causes the release of oxygen-free radicals, impairing our healing and leading to more inflammation. Fluid inflammatory debris start to collect, and they create a thick solution. So remember, before we talked about fluid leaking out of the capillaries and looking like serous fluid? All right, well, this fluid also contains inflammatory debris, so it's going to be more like pus than like serous fluid, and that's going to decrease our gas exchange and stimulate even more inflammation. ARDS goes through these phases, the first of which is called the latent phase, and we have the symptoms of the underlying disease. So in a case study that we had with Mr. Franklin, all of his symptoms on presentation and in the first 24 hours were all related to his underlying disease, to his trauma. Then we go into the acute interstitial edema phase. In this phase, we start to see the drop in PO2 FiO2 ratio. We get some subjective dyspnea. Move into the acute intraalveolar edema phase, and now we're starting to get decompensation with alveolar flooding. This is when that patient really starts to get into that refractory hypoxemia. And then lastly, we move into the subacute or chronic phase, where the patient has this chronic inflammation and scar formation inside the lung. So on his third day after admission, Mr. Franklin is extubated and sent to the floor. Shortly thereafter, he develops increasing respiratory distress and hypoxemia. Okay, now look at his blood gas. He's on a 40% veni mask, and his O2 is 65. What is his PO2 FiO2 ratio? His PO2 FiO2 ratio is 162. So it looked like he was starting to get better, but remember, we were at 230, and 230 is not normal. Normal is greater than 300 on the PO2 FiO2 ratio. So he was still less than, now he wasn't in that less than 200 range that we call ARDS, but he was still low. So we sent him to the floor, and this happens frequently, is that the patient's starting to look good from some of the characteristics. So his vital signs were stable. Maybe the rest of his injuries looked like they were stable. So we thought, hey, well, let's send him out to the floor. And then we find out that ARDS has been brewing in the background. So in this case, it's 162. That's considerably low. We have to be worried about ARDS in Mr. Franklin. Pulmonary edema forms in ARDS, and I've alluded to this already, but let's take a look at it in a little bit more detail. The first phase we talked about was latent phase, and in the latent phase, we get a little bit of problems that are occurring. So we're starting to see some inflammation that is forming in that interstitial space. So this is the space between that capillary. So this little thing down here at the bottom there with the arrows in it is the capillary, and then the alveolus. So we're getting some fluid starting to build up in that interstitial space. Not much, just a little bit of pressure in there. Things are starting to change. Then we move into the interstitial edema phase. Now you see fluid is building up in the interstitial space. This makes the lungs less compliant. And since they're less compliant, the patient's going to feel subjective dyspnea. And maybe the patient's respiratory rate is like 22, 24. You're probably thinking, no big deal. Geez, lungs are clear. Okay, I could look at the alveolus. There's nothing in the alveolus. The fluid is in the interstitial space. Next, there's enough fluid in that interstitial space that we flood the alveolus. Now we have the alveolar flooding. Now you hear the rouse. Now you see the whiteout on the chest x-ray. Now the patient starts to crash. But can you see how this was coming? And we could anticipate it along the way if we're paying attention to those subtle signs. Increase in respiratory rate with subjective dyspnea. A number of different things happen in ARDS. In that initial phase there, in the first day or two, we have lots of edema formation. At that same time, we start forming this scar tissue, the hyaline membranes. Notice that continues out for about 2 weeks, that we continue to have more scar tissue formation. Interstitial edema starts to occur at about day 5. Along with interstitial inflammation. So those things start occurring at about day 5, peak out there at about day 10 after that initial insult. So our medical and nursing interventions include reversing the underlying pathophysiology. This is the most important component here. So we want to treat the trauma, we want to treat the infection, turn off the stimulating factor. We've tried a lot of things over the years to try to block the mechanism of the alveolar capillary membrane injury with limited success. So a number of different things that are mentioned here. You might see them used in one form or another, depending upon what else is wrong with your patient. And we've had limited success with those options. One of the most important interventions that we can do is aggressive pulmonary hygiene, turning, positioning, rotational beds, prone positioning. We're seeing a renewed interest in prone positioning with COVID-19. Suctioning, bronchodilators, vibration, and percussion, everything we can do to try to improve that pulmonary function and that patient mobilize those secretions, keep those airways open, and improve oxygenation. So we want to minimize the pulmonary edema. Now, from a hemodynamic standpoint, you got a patient like Mr. Franklin who is in shock, so he has got hemodynamic issues that we have to deal with. While at the same time, we don't want to be giving him too much fluid because with that capillary permeability, where's it going to go? It's going to dump in his lungs. And it's going to mix with inflammatory debris. It's going to be thick like pus, and we can't get it back out. So we want to budget our fluid administration, be aware of how much fluid we're giving, and be aware of seeing some of those changes that are occurring in the lung if too much fluid's getting in there, like subjective dyspnea and an increase in respiratory rate. Maintain our tissue oxygenation by balancing our oxygen delivery with consumption. Consider alternative methods of mechanical ventilation and maintain nutrition. Use the lowest possible PaOP that will maintain an acceptable cardiac output in our patient. Use the lowest possible FiO2 without risking hypoxemia. And mechanical ventilation, we're going to be using more moderate levels of PEEP and lower levels of tidal volume. This has really started to become the standard in mechanical ventilation over the last 10 years or so. It's interesting that we've known about low tidal volume strategies for 20, 30 years, but they've only started to become in vogue in the last few years. Prone positioning, as I mentioned before, has gotten a lot more attention now with COVID-19. It helps to recruit the alveoli in the bases of the lungs. So when you take a look at this picture on the right here, one of the things you may notice is that the heart overlaps the lower lobes, especially on the left side. So when the patient is laying on their back, we're going to have not only the weight of their body and the weight of their heart pressing on the lungs, but we're also going to have gravity working to pull fluid down into the bases in the back. Well, the bases in the back are the best area of the lung. That's where the best perfusion is. So we need to get oxygen down there so we can take advantage of that really good perfusion. By flipping that patient over, you can see it pops that heart off of those lower lobes, so the lower lobes can reinflate, and it helps redistribute the airflow through the lung, which helps to decrease lung injury. We've seen that prone positioning dramatically increases our patient's oxygenation and also is associated with decreases in mortality. Proning must be done early for a maximal benefit in ARDS. Okay, there's a number of different ways to do it. You can do it manually, just having a bunch of people come to the bedside and turn the patient. Make sure you got enough people. Don't try and do this with 1 or 2 people, or you're going to pull out tubes. Positioning must be maintained for 12 to 16 hours. Ideally, 12 to 16 hours. We'd like to keep the patient in that position. It really takes a while for fluid to redistribute, for hemodynamics to redistribute. If your patient is becoming severely unstable within the first 30, 40, 50 minutes, whatever, and you have to turn them back on their back, you're not going to see the same kind of benefit that you would see from prolonged proning. Complications. So these are the big things here to be really aware of. Tube dislodgement. Pulling out IVs, pulling out tubes. This is the big thing. Make sure you got enough people to prone this patient so that you can watch all those tubes and we're not pulling out something important, well, like an ET tube, you know. Hemodynamic instability. And anticipate. Hemodynamics are going to change when you put the patient in the prone position. We're doing a lot of changes with the patient's fluid volume status. We're changing how the heart's working. There's going to be changes in hemodynamics. Pressure injuries, eye injuries, from pressure on the eyes, on the face, the shoulders, the hips, the knees. So we want to make sure that the patient is adequately positioned and adequately padded to help prevent pressure and eye injuries. To summarize, look for risk factors. So we want to be looking for those and being aware of those risk factors. Assess the PO2-FiO2 ratio. Prone the patient early. Use protective ventilation. That's the low tidal volume strategy. Watch your volume resuscitation. Be aware of how much fluid you're giving to the patient. Be listening to those lungs, watching that respiratory rate. Thorough assessment, diligent pulmonary hygiene, and we can improve outcomes in our ARDS patient. Thank you for joining me for Acute Respiratory Distress Syndrome, ARDS. My name is David Woodruff, and until next time,